Welcome to the Deep Dive, the show where we take a stack of information and distill it into something you can truly use. Today, we're plunging into a topic that touches a primal fear in so many of us: chest pain.
Mm-hmm.
It's that symptom that sends millions to emergency departments every year, and, for good reason. That terrifying sensation can be the siren song of something life-threatening. An acute coronary syndrome, or ACS.
That's exactly right. And for this deep dive, our mission is really to move you beyond just simple definitions. We want to give you a shortcut to truly understanding the sheer complexity of ACS.
You mean like all the different ways it can show up?
Yeah, exactly. How it manifests, the crucial diagnostic pathways, and the precise, life-saving treatments involved.
And we're not stopping there. We'll also explore the often overlooked complications with a special focus on the heart's other side, the right ventricle. It's kind of an unsung hero in cardiac emergencies, isn't it?
It really is. Our insights today come directly from highly specialized medical literature and emergency medicine manuals. So you're getting an expert-level understanding distilled for you, no wading through dense textbooks.
Okay, great. So let's get into it.
Let's do it.
To truly understand this complex picture, we have to start with the fundamental question. What is an acute coronary syndrome? We hear that term ACS, but it's actually a spectrum of conditions, right?
It absolutely is. ACS isn't one single thing, but rather a group of clinical conditions. They all typically present with chest pain or discomfort, and the root cause. It's myocardial ischemia, which just means reduced blood flow to the heart muscle.
Okay.
And within ACS, there are three main types.
Right. We have STEMI and NSTEMI and unstable angina. Can you quickly lay out the distinctions? What makes them different?
Sure. So STEMI, that's ST segment elevation myocardial infarction. It's recognized by very specific electrical patterns on the ECG. Think of it like a sudden blaring alarm on the heart's electrical map. It signals a complete blockage.
Like ST elevation?
ST segment elevation, yeah, or maybe a new left bundle branch block. That's a major electrical short circuit in the heart's lower chambers, often a really strong sign of serious trouble.
Okay, that's STEMI. What about the others?
There's a STEMI-HEL, non-ST segment elevation myocardial infarction. This involves other ECG changes, maybe ST segment depression or T-wave inversion, more like a flickering yellow light indicating stress or maybe partial blockage. Or it could even be a normal ECG. But crucially, with NSTEMI, there's a release of cardiac troponin.
Ah, troponin. That's the heart attack enzyme people talk about, right? The biomarker.
Exactly. Troponin is like the smoke detector for heart muscle damage. If it's elevated, it means some heart cells have actually died.
Okay. And the third one, unstable angina.
Right. Unstable angina, or UA. This one also has other ECG changes, or maybe a normal ECG, but, and this is the key, with consistently negative troponin, so no troponin rise in UA.
So the key takeaway here is chest pain isn't just one alarm bell. It's like a whole symphony of signals. And knowing which instrument is playing or not playing is literally life or death.
That's a great way to put it.
The core problem is that sudden reduction in blood flow. But the type of blockage, whether it's complete or partial, that makes all the difference in how we classify it.
That's precisely it. In most cases, ACS is triggered by coronary artery disease.
Yeah.
It usually starts when an atherosclerotic plaque, a fatty deposit in a coronary artery, ruptures or erodes.
Okay.
This triggers the artery wall to constrict, and a blood clot, a thrombus, forms. That obstructs the vessel and critically reduces blood flow to the heart muscle.
And you mentioned the clot itself can be different in these conditions. That affects treatment, right? How so?
Yeah, that's a key distinction. In STEMI, it's typically a fibrin-rich thrombus. Imagine like a concrete dam. It causes a total, often irreversible occlusion of the coronary artery.
Right, complete blockage.
But in NST-ACS, that includes both NSTEMI and unstable angina, the thrombus is often platelet-rich, more like a flimsy sandbag dam. It leads to partial occlusion, or maybe one that fluctuates. That's why NSTEMI and UA can be trickier, often more dynamic in how they present.
Okay. Now, when someone has chest pain, we all picture that classic Hollywood heart attack, clutching the chest, maybe collapsing. But our sources suggest it's not always what happens, is it?
Oh, far from it. That's a huge misconception.
So forget what you think you know from the movies.
Pretty much. What you see on screen is often the exception, not the rule, in real life. The textbook chest pain is heavy, aching, or tight, usually center or left side of the chest, lasting longer than 15 minutes, maybe radiating to the arms, neck, or jaw. And it's typically not related to breathing or movement. Plus, you might get nausea, vomiting, marked sweating. We call that diaphoresis or breathlessness.
Okay, that's the classic picture. But here's the crucial twist. Not everyone gets that right.
Right, and this is a critical point for you to understand. The prevalence of atypical presentations. Our sources say maybe 20 to 33% of patients don't get that classic pain.
A third. That's huge. Who are these patients typically?
Especially elderly people, individuals with diabetes, females, and those with kidney disease. They might experience little or no chest discomfort at all.
So what do they experience?
Their main symptom might just be breathlessness, or even things like back pain, abdominal pain, dizziness, or palpitations. This is why you always need a high index of suspicion. You can't just rely on chest pain.
That makes sense. So with such varied symptoms, how do clinicians actually sift through it all to identify a real AMI, an acute myocardial infarction? What clues come from the patient's history?
Well, we use something called likelihood ratios. It's a way to quantify the probability.
Likelihood ratios. What does that
Yeah.
mean in simple terms?
It basically tells us how much more or less likely a condition is when a specific symptom is present. So, for instance, pain radiating to the right arm or shoulder, or to both arms, significantly increases the chance of AMI, makes it almost 5 times more likely.
Okay.
Conversely, pain described as pleuritic, sharp with breathing, positional, or if you can reproduce it by pressing on the chest wall, that makes AMI much less likely.
But, and this sounds important, no single factor can nail it down, can it? You can't rule it in or out based on just one thing.
That's absolutely true. You can't hang your hat on one symptom alone. And here's a really crucial counterintuitive insight. That burning sensation, you might think, oh, it's just indigestion.
Yeah, heartburn.
Right.
Right.
But our sources say that in emergency department patients, burning pain can actually increase the probability of AMI. So you have to be cautious. Never just dismiss it.
Wow, okay. What about the physical examination? What do clinicians look for? Any red flags there?
Often, the physical findings are pretty nonspecific. The patient might look pale, anxious, sweaty, maybe have a rapid heart rate or breathing.
Mm-hmm.
However, there are specific signs that increase the likelihood of AMI. Things like a third heart sound, that's an extra heart sound suggesting fluid overload, or hypotension, very low blood pressure, or pulmonary crepitations, those crackling sounds in the lungs that indicate fluid. These point towards more serious heart involvement.
Okay. So we're building this complex diagnostic puzzle from the history and the physical exam. The next crucial step is about immediate action, right? What's the very first thing that happens when someone with suspected ACS hits the ER?
A prompt 12-lead ECG, absolutely crucial. It's the first big step that determines the patient's immediate management pathway. Like, do they need immediate reperfusion opening the blocked artery right now, or more of an antithrombotic strategy using blood thinners?
We mentioned those electrical patterns earlier, ST elevation and ST depression. Can you simplify what those tell you? Is it like a warning light flash?
Yes, exactly. Think of the ECG as a real-time electrical map of the heart, ST segment elevation. That's like a blaring red light. It usually indicates a complete arterial blockage, a major heart attack, a STEMI happening right now,
And depression.
ST depression, or maybe T-wave inversion. Those are more like a flickering yellow light, a warning of stress, or maybe a partial blockage, an NSTEMI or a UA potentially. And that new left bundle branch block we talked about, that electrical short circuit, also a very serious sign, often treated like a STEMI.
Okay. Now, does ST elevation always mean heart muscle is dying? I've heard about aborted AAIs or coronary artery vasospasm. Can you clarify that?
That's a great question. While ST elevation with ischemic chest pain usually means an evolving heart attack, you're right, it's not always the case. It can sometimes be seen in aborted myocardial infarction, where maybe early reperfusion, like a clot dissolving on its own, actually prevented tissue death.
Ah, okay.
Or it could be coronary artery vasospasm, where the artery just temporarily clamps down and then relaxes without causing permanent damage.
Interesting. And the ECG can actually help doctors pinpoint where the heart attack is happening in a STEMI. How does that work?
Yeah, it's pretty amazing. The 12-lead ECG gives us 12 different views of the heart's electrical activity, kind of like different camera angles. Changes in specific combinations of these views, these leads, can tell us which part of the heart muscle is affected.
Like front, bottom side.
Exactly. Anterior, inferior, lateral. And by extension, we can often figure out which major coronary artery is likely blocked. It's like using an electrical roadmap of the heart.
So even if the ECG looks completely normal initially, that doesn't mean someone's in the clear, right? You can't just send them home.
Definitely not.
Yeah.
A normal ECG significantly reduces the probability of AMI, sure, but it absolutely does not allow safe discharge without further investigation. That's a critical potential pitfall. You need more information.
Okay. So beyond the ECG, what about those cardiac biomarkers, troponin specifically? How does that confirm heart muscle damage? You called it the smoke detector.
Right. Serum troponin, either I or T, is the preferred cardiac biomarker. And NSTEMI is specifically diagnosed when you find an elevated troponin level in a patient who has symptoms consistent with ischemia that reduce blood flow.
And timing is key with troponin, isn't it? It doesn't show up immediately.
That's crucial. Troponin levels take time to rise. It can take up to 8 hours, sometimes even longer, from the start of the infarction for them to become detectable or peak.
So one test might not be enough.
Exactly. If there's diagnostic uncertainty, repeating the troponin level, usually within about 3 hours, is recommended. Now, for very low-risk patients, a single high-sensitivity troponin test right at presentation, if it's below the lower limit of detection, can sometimes rule out NSTEMI effectively. But otherwise, yes, serial measurements are vital.
Makes sense. What other investigations typically get done alongside the ECG and troponin?
Well, a chest X-ray is usually done. It's useful for diagnosing complications like pulmonary edema fluid in the lungs, or for ruling out other things that can cause chest pain, like a collapsed lung, a pneumothorax. And echocardiography, the heart ultrasound, is also really important. It assesses how well the main pumping chamber, the left ventricle, is functioning. That LV function is directly related to the patient's prognosis.
And it can spot other things too.
Yeah, echo can help diagnose other conditions like cardiomyopathies, valve problems, even aortic dissection sometimes. Or it can pick up mechanical complications of the heart attack itself, like a hole in the heart wall.
So once these initial tests are done, ECG, troponin, maybe X-ray, and echo, how do clinicians then risk stratify patients? How do they decide who needs the most urgent care or specific treatments?
Right. Once unstable angina or NSTEMI is suspected, a formal risk assessment for future adverse cardiovascular events is really crucial. We use established scoring systems for this, like the GRACE score.
Grace? What's that?
GRACE stands for Global Registry of Acute Cardiac Events. It's a validated tool that helps predict a patient's risk of dying within the next 6 months.
And what kind of factors go into a score like Grace? Is it complicated?
It considers several things: the patient's age, their heart rate, blood pressure, kidney function, creatinine level, their Killip class. That's a quick way to assess signs of heart failure at the bedside.
Okay.
And also whether they had a cardiac arrest when they presented, if there were specific ECG changes like ST deviation, and of course whether cardiac markers like troponin were elevated. All these factors together give a pretty comprehensive risk profile.
And what about those patients who seem like low probability ACS? You know, the ones where initially there's no clear evidence of a heart attack or ischemia. Do they just get sent home if the score's low?
Even in those cases, risk stratification is still vital. While the objective evidence might be absent initially, a small but significant percentage of these patients can still develop adverse cardiac events later on. So we can't just be complacent, even with a low initial risk score.
So if suspicion continues, maybe the pain comes back, even with negative initial tests, what's the rule-out process then? What happens next?
For those patients where suspicion lingers, advanced cardiac testing is considered. There are several options. One is CT coronary angiography, or CTCA.
That's like a specialized CT scan of the heart arteries?
Exactly. It's particularly good for lower-risk patients, it's relatively fast, and cost-effective for ruling out significant blockages. Other options include exercise stress tests, stress echocardiography, doing an echo while stressing the heart and cardiac MRI. These tests help definitively rule out ACS or maybe find other reasons for the symptoms.
Okay, so we've diagnosed it, we've risk stratified. Now the clock is ticking, especially for STEMI. What's the immediate life-saving game plan? What's that cardiac first aid they get right away?
Yeah, the immediate goal is twofold: increase oxygen supply to the heart muscle and reduce its oxygen demand. First up is aspirin. A 300 milligram oral dose, crushed or chewed, should be given as soon as possible.
Why crushed or chewed?
Faster absorption. Aspirin is incredibly cost-effective and actually provides a survival benefit similar to thrombolysis, those clot-busting drugs. It's foundational.
Okay, aspirin first. What else? I imagine GTN spray or tablets for pain.
Yes, sublingual glyceryl trinitrate, or GTN, is given for ongoing chest pain, the angina. Then there's oxygen. But, and this is important, it's only given if the patient is hypoxic, if their oxygen saturation is below 94% on room air.
Only if needed, not routinely.
Correct. The aim is 94 or 98% saturation. Unless they have COPD, then maybe a bit lower. The key thing is to avoid excessive oxygen. Giving too much oxygen to someone who doesn't need it can actually potentially increase the infarct size, the area of damage.
Wow, okay. less is more sometimes. And for the pain and anxiety, that must be immense. Opiates.
Precisely. Intravenous diamorphine or morphine are the drugs of choice. It's not just for comfort, though that's important. Pain and anxiety ramp up the sympathetic nervous system, which increases the heart's workload. So treating them helps the heart.
Right.
And antiemetics might be given too, as nausea and vomiting can happen.
And what about beta blockers? Are they part of this immediate care package?
Yes, beta blockers are also very beneficial right up front. They help with pain and anxiety too, and they've been clearly shown to reduce mortality in this setting. So they're usually given early unless there's a contraindication.
Okay, so that's the initial stabilization. For STEMI, though, opening up those blocked arteries reperfusion is incredibly time-sensitive, isn't it? Every minute literally counts.
It is absolutely urgent. Time is muscle, as they say. Every minute of delay means more heart muscle potentially dying.
And the preferred strategy, the one we hear about most, is primary percutaneous coronary intervention, or PPCI. Can you explain what that involves?
Sure, PPCI basically means angioplasty or stenting. It's the preferred coronary reperfusion strategy for STEMI. What happens is doctors insert a thin tube, a catheter, usually into an artery in the wrist or groin.
Huh?
They thread it up to the heart, find the blockage in the coronary artery, and then they can inflate a small balloon to open the artery up. That's angioplasty. Or place a tiny mesh tube called a stent to prop the artery open.
And this is better than clot-busting drugs.
Generally, yes, if it can be delivered quickly. The goal is usually within 120 minutes of when fibrinolysis, the clot buster, could have been given. And ideally, the patient should present within 12 hours of symptoms starting. PPCI is highly effective. It achieves and maintains artery patency better, and it has a lower risk of major bleeding compared to thrombolysis. It's also definitely preferred for patients in cardiogenic shock or those who have reasons not to get clot-busting drugs.
Okay, but what if PPCI isn't available within that critical 120-minute window? Maybe the hospital doesn't have a cath lab, or it's too far away. That's where fibrinolysis, the clot busters, come in.
Exactly. Fibrinolysis, using those clot-dissolving drugs, is the alternative if timely PPCI cannot be delivered. This applies to STEMI patients presenting within 12 hours of symptom onset.
Right.
And there's a clear, though nonlinear, relationship between how quickly it's given and the outcome.
Getting faster is much better.
Much better. The shorter the time from symptom onset to treatment, the greater the benefit. For example, our sources mentioned that giving it within the first hour can prevent maybe up to 60 deaths per 1,000 patients treated compared to later treatment. It's a huge difference early on.
But these are powerful drugs. What are the main risks? You mentioned bleeding.
Yes, the main hazard is hemorrhage, bleeding, particularly intracranial hemorrhage, bleeding inside the brain. It's not common, but it's a serious risk, maybe around 4 extra brain bleeds per 1,000 patients treated.
So there must be situations where you just can't give it, contraindications.
Absolutely. Absolute contraindications include things like any history of prior bleeding in the brain, having had an ischemic stroke within the last 3 months, known structural problems in the brain's blood vessels, active internal bleeding, or suspected aortic dissection.
Okay, so here's a tricky situation I imagine comes up. What about a patient who's already on warfarin, a blood thinner? Can they get fibrinolysis? That sounds incredibly risky.
It is incredibly tricky. This becomes a very complex, individualized decision. You have to weigh the potential benefit of opening the artery against the significantly increased risk of bleeding.
So what do they do?
Often, it requires an urgent INR check. That's the blood test measuring how thin the blood is. If the INR is way above the therapeutic range, say over 3.0, it would generally be considered too dangerous to give thrombolysis due to the very high bleeding risk. It really depends on the specific INR level and the clinical context.
Makes sense. And even if thrombolysis is successful initially, it's not usually the end of the story, is it? I've heard the phrase, lyse now, stent later.
That's a good way to think about it. Even if the clot buster works and restores flow, it often isn't the definitive treatment for the underlying blockage. So angiography, looking at the heart arteries with dye, is usually recommended before discharge, typically within 6 to 24 hours after successful lysis, to confirm the artery is open, assess the residual blockage, and perform PCI, stenting, if needed. This strategy, sometimes called pharmacoinvasive therapy, has been shown to improve outcomes compared to lysis alone.
Okay. Beyond aspirin, what other anti-clotting therapies, antithrombotics, are given?
Good question. For patients undergoing PPCI for STEMI, other potent antiplatelet drugs are essential. These prevent platelets from sticking together. Options include clopidogrel, prasugrel, or ticagrelor. Often, prasugrel or ticagrelor are preferred over clopidogrel in this setting because they're more potent and work faster.
And for NSTEMI or unstable angina?
For NSTEMI UA, the approach involves anticoagulants like fondaparinux, unless there's a high bleeding risk or immediate angiography is planned, in which case unfractionated heparin might be used. And dual antiplatelet therapy aspirin plus usually ticagrelor or clopidogrel is also critical for these patients.
So shifting focus slightly to managing NSTEMI or unstable angina specifically, it sounds like there's maybe a bit more time to decide on angiography compared to STEMI.
Generally, yes, unless the patient is unstable. For intermediate or higher risk patients, remember that GRACE score predicting 6-month mortality above 3.0%. Coronary angiography with follow-on PCI, if indicated, is usually offered within 96 hours, so within 4 days.
And if they're very unstable, chest pain continuing, signs of heart failure.
For clinically unstable patients, angiography should be performed as soon as possible, often emergently.
Okay. And what if they're considered genuinely low risk? Maybe their GRACE score is less than 3%.
For those truly low-risk patients, a more conservative management strategy without routine early angiography is a reasonable option. That usually involves optimizing medical therapy. Of course, if they subsequently develop recurrent ischemia or other high-risk features, then angiography would be indicated.
Makes sense. After the acute event is managed, whether it was STEMI or NSTEMI, secondary prevention becomes absolutely key for long-term health, doesn't it? It's not just about surviving the initial event.
Absolutely critical. Long-term management is vital to prevent future events. This typically involves aspirin daily, usually for life. For high-risk patients who had ACS or PCI, dual antiplatelet therapy, aspirin plus another agent, is continued for at least a year.
What else?
Then there are ACE inhibitors or similar drugs called ARBs. These help relax blood vessels, lower blood pressure, and reduce the risk of developing heart failure and future MIs. Beta blockers are also continued long-term as they reduce mortality. And statins, the cholesterol-lowering drugs, are crucial for stabilizing plaques and reducing future coronary events, regardless of the initial cholesterol level.
And the lifestyle changes, they're just as important, right?
Oh, absolutely. You can't underestimate them. Things like adopting a low-fat, high-fiber diet, getting regular exercise, and definitely smoking cessation if the patient smokes. These are foundational to long-term heart health and work synergistically with the medications.
Okay. So even with all these advanced treatments, complications can still happen, especially after a big heart attack like a STEMI. What are some of the common ones?
Yeah, unfortunately, complications can occur. One common one is pulmonary edema. This basically indicates left ventricular failure. The main pump is struggling, and fluid backs up into the lungs.
What does that look like?
The patient becomes increasingly breathless. Their oxygen saturation might drop. They might have a rapid heart rate, maybe that third heart sound we mentioned earlier, and you'd hear crackling sounds, crepitations, when listening to their lungs.
How's that treated?
Treatment focuses on reperfusion, if it hasn't happened already, using diuretics like furosemide to get rid of the excess fluid, and sometimes non-invasive ventilatory support like CPAP or BiPAP to help with breathing.
And what about cardiogenic shock? That sounds really serious.
It is. Cardiogenic shock, usually due to severe left ventricular dysfunction, is an ominous complication. It means that the heart damage is so significant that it can't pump enough blood to meet the body's needs.
How does that present?
Patients show signs of systemic hypoperfusion, not enough blood flow to vital organs, so very low blood pressure, cool, clammy skin, maybe confusion, and reduced urine output. Early and effective reperfusion, especially with PPCI, offers the best chance, but mortality is still very high.
What else can be done for shock?
Sometimes drugs that help the heart squeeze stronger, called inotropes, are needed. And mechanical support devices, like an intra-aortic balloon pump or more advanced devices, might be used to help support the circulation while the heart recovers.
Beyond heart failure and shock, are there mechanical problems, like the heart tissue itself tearing?
Yes, unfortunately. These are less common now with rapid reperfusion, but they can happen. Mitral regurgitation is probably the commonest mechanical issue, where the mitral valve starts leaking badly due to damage to the supporting structures. This presents with a new heart murmur and often acute heart failure. Then there's ventricular septal rupture, which is literally a hole forming in the wall between the two main pumping chambers, the ventricles. This also causes a loud murmur and sudden deterioration. And the most catastrophic is free wall rupture, where the outer wall of the ventricle tears, leading to blood leaking into the sac around the heart cardiac tamponade, causing sudden collapse.
Wow. And these require surgery?
Yes, these mechanical complications usually require urgent surgical repair, which is itself very high risk.
And of course, the heart's electrical system can go haywire after an MI, right? Arrhythmias.
Absolutely. Electrical instability is common. Ventricular fibrillation, or VF, a chaotic rhythm where the ventricles just quiver, is a major cause of sudden death, especially before the patient reaches the hospital. Immediate defibrillation, that electrical shock, is the only treatment.
What about other rhythm problems?
Other arrhythmias like atrial fibrillation or AFib can occur, increasing stroke risk. And various degrees of heart block, where the electrical signals from the top to the bottom of the heart are flowed or completely blocked, can also happen, especially with inferior MIs. These might require temporary or even permanent pacing with a pacemaker.
Okay. Now, this next part is where you said it gets really interesting, focusing on the heart's other side. We've talked a lot about the left ventricle, the main pump. But the right ventricle, the RV, you called it an unsung hero, but critical when it fails. Tell us about acute right heart failure, or RHF.
Yeah, this is a really important area and often underappreciated is a great quote from Professor Michael Pinsky. The right ventricle is not important until it is, and once it is important, it is everything.
Wow. What does that mean?
It means that often the RV just does its job quietly in the background. But when it fails, acutely, the consequences can be devastating. And interestingly, as our treatments for left heart failure have gotten better, RHF is increasingly becoming the final common pathway. The reason why patients ultimately succumb to their heart disease. It's frankly less forgiving than the left ventricle when it gets acutely stressed.
So how do we actually define right heart failure? What is it?
It's primarily a clinical diagnosis. It's characterized by signs and symptoms of systemic congestion, meaning fluid backing up in the body's veins, combined with evidence of structural and/or functional abnormalities of the right side of the heart, often seen on echo.
You describe the underlying pathophysiology as a potential spiral of death. Can you break down the mechanisms? What makes the RV fail, and how does it create this vicious cycle?
Yeah, there are three main ways the RV gets into trouble, and they often feed off each other. First is impaired contractility. A key difference is that the RV gets its blood supply during both diastole relaxation and systole contraction. So if the patient becomes hypotensive, low blood pressure, the RV's own blood supply drops significantly. This risks ischemia, damage, and weakens its pumping ability.
Okay, so low blood pressure is really bad for the RV itself. What's the second mechanism?
Pressure overload. The RV is a thin-walled chamber. It's designed to pump blood into the low-pressure pulmonary circulation, the lungs. It does not tolerate sudden increases in pressure well at all. Think about a massive pulmonary embolism, a big clot in the lung arteries. That sudden high pressure can acutely overwhelm the RV.
Right. And the third?
The third is volume overload, and this relates to something called ventricular interdependence. The two ventricles share a wall, the septum, and they sit together inside the pericardium, the sac around the heart. If the right ventricle becomes acutely dilated because it's overloaded with volume, it physically pushes the septum over into the left ventricle.
So it squishes the left ventricle.
Exactly. It impairs the left ventricle's ability to fill properly during diastole. And if the LV can't fill, it can't pump effectively, so overall cardiac output drops. This can worsen hypotension, which further impairs RV contractility. And you see how the vicious cycle, that spiral, starts.
Yeah, I can see that. And this is where it gets really fascinating and maybe counterintuitive for listeners, because some common treatments we use all the time can actually be harmful in acute RHF. This feels like a real aha moment.
It absolutely is.
Yeah.
This is where understanding the specific physiology is critical. Let's take intravenous fluids, for example. If a patient is hypotensive, the knee-jerk reaction is often give fluids.
Right, fill the tank.
But if that patient has acute RHF with volume overload, their RV is already dilated and struggling. Giving more IV fluids can actually make things worse. It further dilates the RV, pushes that septum over more, impairs LV filling even further, and can actually drop the blood pressure more.
So fluids can make hypotension worse in this specific case. What should be done instead?
In many cases of RHF with volume overload and congestion, diuretics are actually beneficial. By removing fluid, they can reduce RV pressures, help the septum move back, improve LV filling, and thereby improve cardiac output and blood pressure, and also improve the RV's own perfusion.
But there's a crucial exception you mentioned, RV infarction.
Yes, this is critical. Patients who are hypotensive, specifically because of a right ventricular infarction, a heart attack affecting the RV, may actually benefit from cautious fluid resuscitation. These patients can be preload dependent. Their damaged RV needs adequate filling pressure to maintain output. So it's not a one-size-fits-all approach. You have to know why the RV is failing.
Okay, that's a huge point. What about intubation, putting someone on a ventilator?
Another potential pitfall. Intubation and positive pressure ventilation inherently increase pressure within the chest cavity. This increased pressure impedes venous return to the right heart and increases the afterload, the resistance the RV has to pump against. Both of these effects can worsen RV function.
So avoid it if possible.
Yes. If you can manage the patient's oxygenation and breathing without intubation, perhaps with non-invasive ventilation carefully applied, that's often preferable in acute RHS. If intubation is necessary, it needs to be done very carefully, using strategies to minimize the negative effects on the RV, things like using low PEEP, positive and expiratory pressure,
Wow.
and avoiding high airway pressures.
Got it. So how do clinicians actually recognize RHF, especially when the classic signs of fluid overload might be subtle or absent in the acute phase? What should they be looking for?
That's the challenge. In acute RHF, the classic signs of chronic fluid overload, like peripheral edema, swollen legs, or massively elevated JVP, neck veins, might not have had time to develop. What might be more prominent are signs of poor perfusion, cool, mottled extremities, confusion, low urine output. Those are really concerning signs.
How can you be sure it's RHF?
A normal or low CVP, the central venous pressure, or seeing a collapsed IVC, the big vein returning blood to the heart, on an ultrasound makes significant RHF unlikely. But really, echocardiography is key.
Right, the echo. What does that show?
Echo is the investigation of choice. It can directly visualize the RV. You look for RV dilation. Is it bigger than the LV? You look for that septal flattening, the D sign we mentioned, where the septum bulges into the LV during systole. And you measure RV function, often using something called TAP-PSE, tricuspid annular plane systolic excursion. It basically measures how much the side wall of the RV moves up and down. A low TAP-PSE indicates poor RV contractility and correlates strongly with mortality.
Okay, so knowing all this, what does good RV-friendly management look like? What's the optimal approach?
It boils down to a few key principles. First, improve contractility and maintain perfusion. That means treating hypotension aggressively. Use vasopressor drugs that squeeze the blood vessels like vasopressin or low-dose adrenaline, epinephrine, or noradrenaline, norepinephrine.
Many to avoid.
Crucially, try to avoid pure alpha agonists like phenylephrine, if possible, as they can increase pulmonary vascular resistance, making it harder for the RV to pump. You might also consider positive inotropes drugs that make the heart squeeze harder, like milrinone, dobutamine, or maybe adrenaline again, depending on the situation.
Okay, maintain pressure, maybe add inotropes. What else?
Second, optimize volume status. This is that careful balancing act. Consider diuretics if the patient is clearly volume overloaded and congested. Use fluids cautiously, and really only if RV infarction is strongly suspected as the cause of hypotension.
Got it.
Third, reduce RV afterload, the pressure it pumps against. Correct hypoxia, low oxygen, because oxygen is a pulmonary vasodilator. It relaxes the lung arteries. Correct hypercapnia, high CO2, and acidosis too. And as we said, avoid intubation if possible, or manage it carefully if needed.
And fourth.
Fourth, and most importantly, treat the underlying cause. Is it a massive PE? Then thrombolysis or embolectomy might be needed. Is it an RV infarct? Then primary PCI to open the blocked right coronary artery is key. Is it underlying lung disease? Treat that. You have to address the root problem.
And for the most severe cases where these measures aren't enough?
For severe refractory RHF, advanced mechanical circulatory support might be necessary. This could involve ECMO extracorporeal membrane oxygenation, basically an artificial heart-lung machine, or specific RV assist devices, RVADs, that take over the RV's pumping function temporarily. These are highly specialized interventions for the sickest patients.
Okay, so just to recap the pitfalls, the common traps in managing RHF that clinicians really need to avoid.
Yeah, the big ones are not maintaining a high index of suspicion for acute RHF in the first place, automatically assuming all RV dysfunction must be due to a pulmonary embolism. It could be an MI or lung disease, etc. Giving too many fluids reflexively for hypotension, potentially making things worse, being afraid to use diuretics when the patient is clearly fluid overloaded, delaying the use of vasopressors to support blood pressure, and perhaps reflexively intubating patients with severe RHF without considering the potential negative consequences. Avoiding these pitfalls requires really understanding that unique RV physiology.
Wow, what an incredible journey we've been on. We started with that initial, often terrifying suspicion of chest pain. We've navigated the really complex landscape of acute coronary syndromes.
Yes, STEMI and NSTEMI and unstable angina.
Exactly. We explored how they're classified, the critical role of diagnostics like the ECG and troponins, and then really dove into the nuanced management strategies for each.
And we didn't stop there. We made sure to highlight the importance of recognizing and managing the potential complications, especially bringing that often misunderstood acute right heart failure into the spotlight.
Right, where those common interventions, if you misapply them, can actually be detrimental. It's quite sobering.
It really is.
Hopefully, this deep dive has given you, our listener, a really robust framework, not just for understanding these complex medical conditions, but maybe for appreciating the incredible interconnected machinery that is your own body.
Hmm.
How might recognizing those subtle atypical signs of heart trouble, or maybe understanding the unique challenges of the right ventricle, how might that change how you approach your own health, or maybe how you might support someone else in a critical moment?
And here's a final thought to leave you with. Despite all these incredible advances we've discussed in treating heart attacks, in managing acute cardiac events, a significant portion of deaths still occur before definitive medical treatment is even started.
Before they even get to the hospital or get that definitive care.
Exactly. What does that tell us? What does that tell us about the sheer power of immediate action, of public awareness when those acute symptoms hit? And maybe about the ongoing challenge of bridging that gap between our cutting-edge medical knowledge and really widespread public understanding and response. It's definitely something to ponder.